I am really excited to introduce our next speaker, Jennie Bever, Executive Director and founder of the Fourth Trimester Organization. Jennie's interest in caring for moms and babies began when her first child was born, when Jennie was still in graduate school. And despite a lot of knowledge and dedication, she struggled to nurse her baby. And an international board certified lactation consultant, or IBCLC, was able to help her successfully breastfeed her son. Because of that experience, Jennie grew an intense desire to help other moms and babies reach their breastfeeding goals. And after she finished her PhD, Jennie completed a rigorous course of didactic and clinical training through the University of California, San Diego Lactation Consultant Training Program, and then became an IBCLC herself in 2009. Jennie is also a breastfeeding researcher, and she holds an appointment as an assistant research professor in the College of Nursing and Health Innovation at Arizona State University. She's active in her professional organizations as treasurer of the Central Arizona Lactation Consultant Association and is a member of the marketing committee on the International Lactation Consultant Association. Jennie and her husband have 4 rambunctious children, and when she's not chasing those little ones around, she's enjoying gardening, music, and spending way too much time on social media. So thank you so much for joining us today, Jennie. We really look forward to your talk about breastfeeding and postpartum depression.
Thanks so much, Corey, for that introduction. All right, let me get my screen share going here. All right, thank you very much. Yeah, that was a long intro for the past 10 years or so of my life. Yeah, I was so honored to be invited to speak today about breastfeeding and postpartum depression. Interestingly, this is the first time I've ever spoken about it, which kind of surprises me. My organization, Fourth Trimester Arizona, is really focused on supporting parents in the fourth trimester. And that largely grew out of my experience as a lactation consultant, supporting new parents and recognizing that a lot of the time, breastfeeding challenges were not necessarily all positioning and latch, that sometimes they were mental health challenges. And also challenges brought about just by the fact that our culture doesn't really support new parents during this time of life. And so in 2017, along with a lot of support from friends and our board, we founded Fourth Trimester Arizona to really change the culture of parenting so no one has to do it alone. But my backdrop on that is that my first entry into maternal and child health was as a lactation consultant. And I became a lactation consultant about 3 years after my first child was born. As you had said, I struggled to breastfeed him and was very lucky that I had the support of an IBCLC to do that. And I feel like becoming and being an IBCLC has created a lens for me as a maternal and child health provider where I see both patients. And so it's been an interesting journey to go through that. I'm also honored to speak about this because I've struggled with my own journey through postpartum depression and anxiety. And I put this picture up. This is me with my second child, who's now 11. And his postpartum journey for me was the first time that I experienced postpartum depression. And it was rough enough that when I started thinking about it to talk about this for this talk, I still get teared up. So this was definitely something that impacted the way that I have dealt with everything moving forward and still impacts what I do. So today I'm going to talk some about what we look at as lactation consultants when we are seeing breastfeeding parents who may have postpartum depression and anxiety, and kind of how I came to this realization as a breastfeeding supporter that perhaps everything I was seeing wasn't always directly related to breastfeeding. So some considerations before we get started. Today, I'm going to mostly talk about mothers and breastfeeding, and those are the terms I'm going to use because those are the terms in the literature. but I want to make sure that I point out that not all nursing parents identify as mothers, and that nursing parents may refer to feeding their infants as chest feeding, body feeding, breastfeeding, or something else entirely, and that many nursing parents pump their milk and give it to their babies in a bottle or cup, and this is still breastfeeding. And now I want to tell you what an IBCLC is, because I feel like this is something I throw around a lot, but not everyone knows what we actually do. So I'm an international board certified lactation consultant. As Corey said, I became one in 2009. And it is actually the highest level of breastfeeding supporter. And our certification requires a lot of training, 95 hours and 500 to 1,000 hours of hands-on clinical experience, as well as passing an international exam. We may be hospital-based, WIC-based, private practice-based, as I am, and public health-based. And as of 2012, our services are covered by private health insurance through the Affordable Care Act. AFSU has a fantastic lactation consultant training program, which if you're interested in being part of that, I'd highly recommend you reach out. Dr. Angela Lober, who asked me to speak, is the director of that program. So what does a private practice IBCLC do, and why does that equip me to begin seeing and noticing and referring for postpartum depression? Well, unusual in the field of maternal and child health, we see both parent and baby as patients. So I chart on both mom and baby. I report to both mom and baby's providers, and I see them for a lot longer than most people. So 1 to 1.5 hour visits are super common. In fact, often they're longer. I see them frequently, and I often see the mom before her postpartum OB visit. So they see their OB, if they're lucky, at 3 weeks. If they're not, at 6. They see me at 3 days often. I do a lot of what I call clinical breastfeeding management, positioning and latch, the things you would think that we would do, focusing on low milk supply, oversupply, infections, bottle feeding and pumping, looking at reasons and causes of lactation failure, infant structure and function, and helping infants improve their feeding. I also do a ton of counseling, which is something that I knew I was going to do when I became a lactation consultant, but I didn't really realize how much of my job would be counseling. So now I want to tell you a story about how I realized that it's my job and I'm often well positioned to identify mental health challenges. And this is a story that will also tell you kind of how I learned I didn't know everything. So in 2012, as I said, the Affordable Care Act came into being, and that meant that those of us who were lactation consultants went from seeing a few patients a month who were paying out of pocket to seeing several patients a day, and often more than that. And I opened a private practice with a partner in 2012, about 1.5 years after my second child was born, and started seeing patients in this practice, and saw people for positioning and latch, all the things that I mentioned before. And one day I had a parent who came to my office, and they had their baby prematurely at 35 weeks, and they were working on getting their baby back to the breast, because in the NICU, they had mostly used bottles. And this isn't an uncommon thing. I do this all the time. And so we worked over several weeks together, and the baby got better and better at taking milk out of the breast, to the point that the baby actually was able to breastfeed solely at the breast. And while the baby was getting better and better at this, the mom was doing worse and worse, and it was marked. The visits with the mom, instead of taking 1.5 hours, were taking 3 hours. And the mom was cycling through mastitis, which is a breast infection, and probably about as sick as most people ever feel, and thrush, which is a yeast infection of the nipple, over and over and over. I was in constant contact with her OB to make sure she was on the right medication. Her OB was amazing. I was in contact with her pediatrician to make sure the baby was being treated for thrush. I was doing, I thought, everything I could to manage this. And her OB and I were both at our wits' end trying to figure out why this kept happening. I finally sat down after a visit with my business partner at the time, Desiree Allison, and I said, there is something really weird going on. I cannot figure out why these mom's visits are taking 3 hours and why she keeps getting so sick. what in the world could be causing such crazy immune deficiency that she would be getting mastitis and thrush over and over and over again, despite the fact that we are treating it. And so we sat and threw around some really crazy ideas for what might have been going on, right? Oh, well, maybe HIV. Well, we threw that one out. Well, I wonder if maybe she has some autoimmune thing. Yeah, I don't think that, you know, and I'm a researcher, so I'm like thinking like SCID, like all these crazy things. And then suddenly we looked at each other and I was like, oh my gosh, she has postpartum depression. And it was like, it hit me like a ton of bricks. And I was like, duh, like anyone who's dealt with this much is going to have some challenges. And she had been telling me that she was having trouble sleeping. She'd been telling me she didn't want to reach out to her spouse because he was clearly having trouble managing having this new baby. And so I met with her and I said, hey, what do you think? Do you think you might have postpartum depression? And she looked at me and she was like, yeah, I think I might have that. And so we got her hooked up with a counselor. Her mom flew out to help her, and we called her OB, who put her on medication right away. And magically, the cycles of mastitis and thrush went away like that. It was almost like magic. And I started to look at my practice very differently after that, because I started to recognize, first off, I was the only one who actually picked up that she had postpartum depression, right? And she was like 6 or 7 weeks in. It took me a long time, but I did figure it out. And the fact that I was actually uniquely positioned to do that. And once I noticed it in her, I started to notice it in a lot of my other patients, that a lot of the time, what they were struggling with and why they kept coming in was because their lives were not set up for them to have a great time in the postpartum period. They were really having a rough time. The other thing we learned during that time was that not all counselors are created equal, and that they are not all equipped to work with postpartum moms. So around the same time that we figured this out, we brought in a perinatal mental health counselor who was actually the mother of one of my son's friends. So I was super lucky, Dr. Kara English, some of you may know. And we embarked on this journey where we now had someone we could refer our moms to that we trusted. And that made a huge, huge difference. And I'm so grateful now that we have so many more perinatal mental health providers in the Valley to refer to, because it was kind of a crazy place to be the only place that we felt like we could refer to for a while there. So I believe really that a lot of the challenges we see with breastfeeding and with maternal mental health are really because we don't have a system of support for maternal and physical health in the 4th trimester here in the United States. We have lack of tradition for social support. So some other countries, they have tradition that supports moms during this time. We don't have any paid family leave. We don't see our maternal health providers until 6 weeks. And so many of us go back to work within 2 weeks or 6 weeks or whatever it is of giving birth. Whereas in other countries, they might not go back for a year. Put this with a backdrop of breastfeeding recommendations, which are totally evidence-based, but which don't take into account things like moms who have to go back to work at 2 weeks, or the fact that we don't have a system of support. The American Academy of Pediatrics recently updated their recommendations that mothers should breastfeed to 2 years and beyond with complementary foods, which is in alignment with the World Health Organization. And this is definitely in alignment with the evidence. We know for sure that breastfeeding reduces the risk of breast and ovarian cancer, heart disease and metabolic syndrome, type 2 diabetes in moms. And in children, you could probably cover this whole slide with what it reduces the risk of. So there's a lot of reasons why moms should breastfeed and probably feel pressured to breastfeed. And we also know that in Arizona, most moms start out wanting to breastfeed. 85% of our moms ever breastfeed their babies. And this is from our most recent breastfeeding report card, which I believe is 2019 data, even though it's from 2022. But by 6 months, only 58% are still breastfeeding. And at 12 months, only 40% are still breastfeeding, even though most moms start out wanting to breastfeed. We also know that our rates of perinatal mood and anxiety disorders around the world are actually very high. Unfortunately, we do not have any great data about what's happening right now. The most recent data that I could find was a large meta-analysis that looked at all of the pandemic and found that across the world, rates of postpartum depression were at about 34%, which is similar to what shows up in this infographic that was from 2020. And that rates of postpartum anxiety have also gone up significantly. I think that probably the rates have gone down somewhat since some things have changed in the last year or so. However, I think we would be crazy to think that after experiencing so much collective trauma, we would magically go back to 15% of postpartum depression. Symptoms of postpartum depression, and what I often see in my clinic, are sadness and anxiety. I often see numbness too, people who are very flat. Extreme fatigue is super common. Difficulty caring for themselves and others, and little interest or pleasure in things, and thoughts of self-harm. I often assess this using the Edinburgh Postpartum Depression Scale. And there are some significant impacts for moms as well. Difficulty bonding, chronic anxiety, exhaustion, and increased risk of substance use disorder. Almost half of pregnancy and associated deaths between 2016 to 2018 in Arizona were related to mental health conditions and substance use disorder. So it has an impact on mom. And something that a lot of parents don't know, myself included when I experienced this the first time, is that postpartum depression impacts children. Children of depressed mothers are at a lot of risk of developmental and cognitive and behavioral emotional problems. And most of us just soldier on and think it's only impacting us, but it definitely is impacting our children. And Molly pointed out a lot of amazing, wonderful things about this, but if you're not doing well, you can't be there for your child, right? You're not going to be able to support your child through a rough time. Now, as far as how maternal depression and breastfeeding interact with each other, it's interesting. We have data that shows that if a mother is depressed in pregnancy, she may be less likely to start breastfeeding, and she may breastfeed less long than someone who is not depressed in pregnancy. We also have data that shows that women who are not breastfeeding are more likely to have higher levels of depressive symptoms than women who are, right? So people who are breastfeeding might be less depressed. A really great study that came out in 2022 that I really liked used PRAMS data, which is from 26 states. Unfortunately, Arizona was not yet in that 2016 PRAMS, but they are, I believe, now. Looked at 29,000 parents that were either interviewed by phone or filled out a paper interview, and were able to show that currently breastfeeding parents in the first 6 months who answered that survey had a significantly lower risk of postpartum depressive symptoms, and that they breastfed for a longer duration. We also know that breastfeeding itself, the actual act of breastfeeding, seems to improve mood. There was a study that looked at mood before and after breastfeeding and found that mothers experienced a decrease in negative mood from the time before they started feeding to after, which is fascinating and kind of points to potentially hormonal things that might be happening in breastfeeding. Another great study looked at infants of depressed mothers who were breastfed or not breastfed, and they found that breastfeeding itself may protect infants against the harmful effects of postpartum depression. Mothers who breastfeed have to pick up their kids, right? They have to look at them, they have to touch them to get them latched, and often they are stroking them to get them to keep breastfeeding. So a lot of the things that we worry about with mothers being disengaged from their children, breastfeeding sort of forces them to do. And so it seems to be protective against some of the harmful impacts. What we also know about breastfeeding postpartum depression is that breastfeeding intention is critical. So if a mother started out wanting to breastfeed and successfully did it, she had a much lower risk of postpartum depression. But if she started out wanting to breastfeed and was unsuccessful, her risk of postpartum depression actually goes up. And for me, this is a lot about expectations. right? We talk about mommy guilt and all these wars and things that go on, but a lot of it is just our expectation of what we think is going to happen during this time. And when our expectations don't meet reality, that's when things kind of go south. So looking at that, knowing that it's critical, I feel like this is the place where we need to start thinking about how we're going to help mothers reach their goals. When I have mothers in my clinic who are showing signs of postpartum depression, which at this point I'm pretty good at kind of teasing them out because I see them for an hour and a half, right? Some of the barriers that I see are lack of identification, right? Nobody's told them that they have postpartum depression, and they may not feel that it's actually making a difference for anyone but them. They may feel they need to be sad to have postpartum depression. At that point is a good time where I often point out that I wasn't actually sad. I was numb and I was ragey. And sometimes that helps. Many have had in the past difficulty finding a perinatal mental health certified counselor on their insurance panel. We are really lucky here in the Valley that Women's Health Innovations takes almost all the insurance available. But in the past, that has definitely been a barrier. And then most of them are concerned that treating their depression with medication, first, that it might be the only way they could treat it, and secondly, that the medication will pass through the milk to baby. Lactation consultants often spend a lot of time helping moms get past these barriers because we have time, we have the evidence, we're great at making referrals, and we communicate with moms' healthcare providers to coordinate care. Some considerations for breastfeeding and antidepressant medications. Talking to moms about the fact that untreated depression has significant negative impacts on their children's development. And then talking about some of the common medications that are used and pulling out my book, right? Medications and Mother's Milk, and saying, okay, we're going to look at this and I'm going to tell you whether or not this is going to be okay. We also know that getting breastfeeding support increases breastfeeding duration. In fact, a Cochrane review pointed out that multiple breastfeeding visits actually leads to increased duration and exclusivity, particularly in preventing mothers from stopping between 3 to 4 months and 6 months. And we also know that parents shouldn't have to struggle. We actually have a federal law that mandates that breastfeeding support and counseling is provided. And this is one of the women's preventive services, and so it should be provided without cost sharing. Especially given the recent infant formula shortage, it really underscores the importance of this provision. What I see in Arizona as big barriers to receiving the clinical breastfeeding support that families need is that many insurance panels don't credential IBCLCs. And in Arizona, 51% of the births are covered by Access, but Access doesn't currently cover breastfeeding support, which is a huge barrier to mothers getting the support they need to meet those breastfeeding goals. WIC is amazing. I adore WIC, and I think they do a fantastic job, but they were never set up to provide breastfeeding support for 51% of families. And in fact, in several Arizona counties, there's one WIC contractor that's responsible for all WIC participants. So there's something that's got to give here for new mothers to actually meet their breastfeeding goals. I was recently part of a legislatively mandated panel, the Maternal Mental Health Advisory Committee. This was led by Access and Sarah Salick, who did a fantastic job with this. And I was so thrilled to be able to make a recommendation to improve maternal mental health that we expand lactation coverage. So this is a recommendation that came through in December of 2022 that Access and other providers of insurance should be reimbursing for this particular service to reduce the risk of postpartum depression. And along with that recommendation were a whole bunch of others, and if you haven't looked at them, they're fantastic. But one I want to point out right now, and one that I wouldn't be able to do my work without, is the recommendation to increase perinatal mental health providers. So perinatal mental health providers are a specialty among mental health providers in terms of their ability to provide specific type of support to new mothers. So along with continuing to increase the number of perinatal mental health providers, it was also recommended that Access and commercial insurers recognize them as a specialty so that mothers, when they are looking for someone to support them in perinatal mental health, are able to find someone on their panel right away and don't have to go through a huge list of providers to find someone who can actually support them. And I promised I would put this slide in for my friend Lakeisha Mohammed and PSI. PSI is leading a training to increase the number of perinatal mental health providers of color, and it is being led by and for people of color only in May. And those of you who are interested in being part of this, there's a link down at the bottom if you want to take a picture of that. I would highly recommend you consider signing up. I know there are a lot of scholarships available for this as well. And, you know, in addition to needing more perinatal mental health providers of color, we also need more lactation consultants of color. We need a lot of things here in our state to make sure that all parents get the support that they need. And I will end my slide with a shameless plug for our 4th trimester villages, which are supported by the Department of Health, PSI, ASU, and many others. These meet every week of the month, depending on which one you want to join, and provide access to resources and support and lots of information on perinatal mental health. Thank you so much for allowing me to talk about this today. And if there's any questions, I'm ready for that.
Thank you so much, Jennie, for this amazing and important presentation, one that hits home for myself as well as many other families. And also love the comment where you stated how you can't take care of others if you're not taking care of yourself first. And good morning again to everyone. My name is Kiera Lyons. As Katie mentioned, I am one of the other postdoctoral scholars within the Maternal Child Health Translational Research team. And I will be doing the Q&A for this session. So first question from Rachel is regarding the story about the mother with persistent infections who was found to have postpartum depression. Can you further explain the link between her depression and the infections? Is there a physical link, or was it more of an indirect social emotional link where the lack of support and other depressive symptoms that impact motivation, energy, etc., cause her to be emptying her breast enough and following through with treatment?
Yeah, that's a really great question. Thanks, Rachel. As far as I know, she was following through with everything she needed to do. She was just not getting enough sleep and not feeling well enough to actually get better, is what I actually saw. Because the minute that she had someone there to support her, to take care of her baby, to make her feel like things were going to get better, she actually started doing dramatically better, even before the antidepressant should have kicked in, to be honest. It was actually her mom showing up and helping her that made a huge difference. And she was very type A. She did everything she was supposed to do as far as treatment goes, but it wasn't until she got that additional support that that she started getting better. And, you know, I see that often in my practice, that moms are not being heard about their concerns a lot. And they're not being supported. And so what might have been just a minor thing, if you're not getting enough sleep and you don't have the time to feed yourself or have any self-care, that you often end up with much, much longer recovery periods from different things. So great question.
Thank you. And we're going to go with one additional question, but I did want you to know, Jennie, that there are several other attendees who have questions in the Q&A section that you can answer after your presentation. So the next question was, good morning. What a wonderful presentation and tremendously important for maternal and child health, mental health, and how breastfeeding impacts population-based public health. Regarding the metrics and goals, how do our facilities improve the PCO5 metric? With COVID, we have seen a slight increase, but not substantial, especially the impact of breastfed newborns, let alone up to 1 year.
Thanks for that, Dr. Rubenstein. I don't know if I know what PCO5 means. I'm guessing maybe this is around starting breastfeeding and continuing breastfeeding up to a year or beyond. How do our facilities improve the metrics? I really think a lot of it is around making sure that parents have support after they leave the hospital. I think that's a lot of what's missing, especially among those who don't have clinical lactation support benefits, because a lot of what is real breastfeeding. And a lot of when people stop is actually after they get home. And so without support, that really realistically should just arrive at their doorstep. If we really want to make it be easy, it's hard to keep going, right? It's really hard. And especially when moms are going back to work so soon. But hopefully I answered your question. Feel free to follow up with me after that too.